overview. Thank you, sir.
Thank you very much, the MC. Let me start on a lighter note. Somebody says, if you want to know the average age of the people in the room when they are singing the second stanza of the national anthem, it reflects in the voice and everything. So thank you very much. And when I saw people on the 7th floor, it was very, very easy for them to actually do it. So good morning, everyone. The Executive Director and CEO of National Primary Care Development Agency, other top government functionaries of the National Primary Care Development Agency and Federal Ministry of Health and Government Agencies generally, the representative of the chair of the Forum of the Primary Health Care CEOs, development partners, civil society, my members of the Nigerian Universal Health Coverage Forum. The pleasure is mine to welcome you on behalf of the chair of the forum, Chief Mrs. Mojima Kajola, who is unavoidably absent. So I'm taking a few slides to tell us about what is Nigerian Universal Health Coverage. Slides, please. So Nigerian Universal, can somebody put up the slides? Nigerian Universal Health Coverage is a coalition of a wide array of stakeholders that are determined to taking advantage of a political transition. Next slide, please. To taking advantage of political transitions to put universal health coverage on the political front burner. And it includes indigenous organizations, donor partners, civil society, and individuals that have a common purpose of advancing universal health coverage initiative in the country. While we are still trying to get the technology to have the slides there, a quick thing about what actually inspired Nigerian universal health coverage. We were actually inspired by this wise saying from a renowned billionaire in our contemporary life. He said this. He said, if you want to solve a very complex problem, ask two questions. And the first question is that, who has dealt with the problem very, very well in the past? And number two question is, what can we learn from them? So going by this, we try as much as possible to see, in terms of making progress in health, who are those that have made real progress, and what can we learn from them? A number of even African countries, without going beyond Africa, have made progress. Ghana considerably, Rwanda, which a lot of people went there for health system pilgrimage. Two things are very, very common. One, they took advantage of elections to put health on political front burner. And we ask ourselves in 2021, ahead of the 2023 election, can we do the same thing in Nigeria? And that was what gave birth to Nigerian USC Forum that was first started at USC 2023 Forum. And next slide then. And then we came together in 2021 and say, how do we have an assemblage of a people that with common purpose, that ahead of 2023 election, we must do things differently and create a health agenda to do that. And I'm very happy that we've made a very, very good progress around that. Second slide. So since 2021 to today, what have we actually done? We've done high-level stakeholders meeting, and it came out clearly that when we are talking about putting health on the political front burner, we have to be very, very clear what exactly in health are you putting on political front burner. That was what gave rise to the citizen-led health agenda that we actually developed ahead of the 2023 election. And we used that and we engaged the media because we know the importance of the media. And then we took advantage of the electioneering processes to engage key aspirants. You can see the picture of in Kano and in Lagos State. If you look at the picture of Kano State, the incumbent governor was part of those people that we engaged to be able to present a citizen-led health agenda and say, these are the priorities that we want you to integrate. We did that in Lagos. And then we believe in convening power. Look at those that have the convening powers as well. So we went as far as the United Kingdom with the Chatham House, and we took the governors there. You can see 3 of our state governors there to actually have interaction in terms of how to advance the universal health coverage work, to present the citizen-led agenda to them. You can see the governors of Lagos State, Nasarawa State, and Agumbe State. The next slide. And again, After the election, we said, okay, the work is just actually starting. So last year, we had a universal coverage health summit where we brought stakeholders together. It was an opportunity to present the health agenda as well. And when the incumbent honorable minister came on board, we invited him and graciously honored our invitation. We had a very, very useful interaction with him. And he honored us by presenting the sector reform, his reform agenda, and asked us to go and scrutinize. And when we scrutinized, we came back with what we call a position paper that articulated the position of the non-state actors in terms of what should be prioritized. And as a result of that, the minister actually officially recognized that. We did not stop there. We took advantage of the UAC Universal Health Coverage Day that took place on December 12, 2023 last year. Mr. President himself was in attendance. And it was a huge opportunity for us to make a presentation to Mr. President in terms of what Nigerians want and in terms of how to advance universal health coverage. And again, we have the opinion that we should not stop at the level of Mr. President, the Honorable Minister. We should work with the agencies. And as part of our strategic plan for the next 1 year, we have decided to work with the agency. In May this year, we had a strategic engagement with the National Health Insurance Agency, which was very fruitful in this particular room, where that conversation, a number of important next steps were actually identified, which we are following up with. It was a very good opportunity for the NHI to present a strategic vision to the stakeholders, which was well understood, and it formed the basis for different stakeholders who were defining their plan in terms of how to support. Next slide. So quickly, in terms of a summary of what have we accomplished as the Nigerian USC Forum, we've been able to develop a citizen-led health agenda, like I mentioned earlier before, presented it to the highest level in Nigeria, to the Honorable, His Excellency, the President of the Federal Republic of Nigeria as well. And we developed a position paper that articulates the position of non-state actors, which was actually read by the Honorable Minister. And as a result of that, you can see a letter by that side that the Honorable Minister wrote as a feedback to the letter that we wrote to him. And he officially identified Nigerian USC Forum as a partner in the implementation of the compact signed between the federal, state, and the partners as well. And then, of course, we have engaged governors and international forum. Next slide, please. So in terms of our key next steps, the most important work of non-state actors is accountability. We're in the process of putting together accountability framework for the NHSRIP, which is going to look at how do we ensure transparency and answerability and other things. We are planning to have a biannual event, which we call the State of the Compact. This is actually inspired by some of us that are used to international politics. That is the State of the Union, the United States of America. So here is the State of the Compact. We are looking at, we've signed Compact last year. Where are we with it? What is the progress that we're doing? Then the next thing is that we want to engage the leadership of all the health agencies. We started with NHI. Here we have with the National Primary Care Development Agency. We are going to engage the NCDC. And again, we know that Nigeria is not Abuja. Abuja is just part of Nigeria. So we want to escalate this work to the state, to the regional level as much as possible, so that this level of coordination, we are able to have it as much as possible. And of course, to commission a study on what is the implication of the sector-wide approach for the Nigerian universal coverage quest, because sector-wide approach is a very, very important policy thrust that we are looking at this. And as a fallout of the conversation with NHI, we are currently doing a client satisfaction survey to actually get feedback from Nigeria. Are they satisfied with the various health insurance scheme, which will help the NHI to redesign their work? Next slide, please. So in terms of key next steps, Of course, a number of them have implemented very well. There is an accountability framework for Basic Care Provision Fund. HSRC did a very great job there. We want to lend our voice in terms of doing that. And on the UAC Day, coming December 12th, I want to bring stakeholders together to reflect on where we are with regards to the universal coverage in Nigeria. Next slide. This is logo of some of those organizations that are part of UAC Forum. Unfortunately, individuals don't have logo, but they are part of the Nigerian UAC Forum as well. Next slide. So this is in terms of coordination arrangement of UAC Forum. So on this note, I would like to thank you very much for listening, and I wish us happy deliberation. Thank you very much.
Thank you very much. Managing Partner, DGI Consult, and co-convener of Nigeria UHC Forum, Chief Dr. Uchan comes first. Chief Doctor, thank you, sir. Chief Dr. Gafar Alawode. So essentially, the Nigeria UHC Forum has two broad objectives. One is to advocate aggressively to make universal health coverage a significant social, economic, and political content of Nigeria's development agenda. The other is to work with key health agencies to look at their mandates and policies and frameworks and blueprints and action plans and see where they can collaborate and partner with them to strengthen their systems and improve results. Thank you very much. I was looking at a document recently, and somebody was trying to define primary health care. And he said primary health care is essential health care that is affordable and that is acceptable to the people, and that promotes the full participation of those people, and so on and so forth. Ladies and gentlemen, the custodian of primary health care in Nigeria today, by the grace of God, is Dr. Muyi Aina, the Executive Director and CEO of NPHCDA. So at this point, on your behalf, ladies and gentlemen, I'd like to please welcome Dr. Muyi Aina for his presentation.
Good morning. I'm trying to think through what is the right protocol, but I guess at least I can start with the elders in the room. So our most elder and the big masquerade, Dr. Lecky, and a lot of other colleagues and friends. I'd just like to say good morning. I believe somebody probably already established the protocol. I apologize for coming late, had to rush in from another meeting that I was leading to come here. It's always a pleasure, really, and a privilege to engage with the Nigeria UHC Forum for me personally, not just because it is a group of elders, or a group of friends, sorry, a group of friends that I've known and worked with and struggled with for many years, but also because personally, and in my current official role as the head of the National Primary Healthcare Development Agency, the Nigeria UHC Forum really is at the center of trying to do my job for me. That's helpful. You know, we like helpful partnerships. Do my job in the sense that the mandate of the National Primary Healthcare Development Agency, at least the way we see it, is to help every Nigerian have access to the basic healthcare services that they need. That's universal health coverage, and that's what you all are trying to achieve. So I think that's a perfectly aligned agenda, and I'm always excited and happy to engage, but also be part of this partnership. I think there's also a history there. The conveners of Nigeria UHC Forum are people that I respect a lot. My brother here, Oloye Gafar Alawode, And my big auntie, Auntie Moji. Most people call her Auntie Moji, but in reality, she's my auntie. Most people don't know that, actually. I remember when we used to run around the streets in Ilorin with Bodayo. That's Ayo Silu, many, many years ago, you know. So this is literally, you know, she's my auntie, and that's the history there. And so I do respect the forum a lot. I will spend the next 10 or 15 minutes really running us through some of the things that we've been up to at the National Primary Healthcare Development Agency. Not so much to give you all of the answers, but to tee up some questions. My understanding is there's a little bit of a panel afterwards. I'm hoping that questions and ideas and suggestions will come from the room. We want to listen as well. We want to do more listening than talking. We want to hear from you because you are also a collective of CSO, and we'll talk a little bit more about that. But we want to hear from you. We want to be guided by you. We want you to have input into what we are doing because we don't have all of the answers. Thank you very much. Is there some way to control the slides? Oh, I just have to tell you. All right, next slide. Okay, so I think it suffices to say here that we have outcomes in healthcare that are not acceptable. Somebody put on here maternal mortality rates, but that's true if you talk about infant, if you talk about child, if you talk about, and that correlates very well with the fact that coverage of the basic services that we need, antenatal care, immunization coverage, malaria prevention and treatment, HIV screening, TB treatment, all of those are far in terms of their reach and coverage from where they really need to be. So it's not a shock that we are making some progress. I think it will not be accurate or charitable to those who have come before us to say we haven't made any progress. I think substantial progress has been made, but we're still moving too slowly, you know, towards where we need to be. And so our mandate over the next, you know, short period that we're here is to really try to see what we can do to build on the work that has been done before us to accelerate progress towards the outcomes. Next slide. Okay. Now I can't even see, but I believe you all can see. At the National Primary Healthcare Development Agency, we have a responsibility for what I call UHC, frankly. But if you break it that surprising. Not the people in this room when I actually say that. People come to me and they want me to collaborate with them to operate and build. I'm like, no, we don't provide services, but we support states and now local governments to try to do a better job of what they should do. We do resource mobilization. Many of you know, both domestic resources, but also international resources that we bring to primary healthcare delivery. Now, what is important, and I always like to clarify for people, is that when we think about resource, people always think about money. And money is very important. Money is very important. We don't have enough. But the truth is we have plenty in this room of resources. The only problem is we don't spend it right. That's the truth. If we spent what we have now right, I think we will cover a lot more ground than we are covering now. And I will say a couple of specific things to that. It's that if I did the mapping of the room, what are you doing? What are you funding? Where? Well, you will find that's changing now because of the swap. But what you would find historically is that everybody is doing, well, half of the people are doing exactly the same thing in the same place, but they don't even know that they're all doing it like that. So there's concentration around certain interests and certain locations. Some other interests and locations are completely neglected. So that's not efficient. But also, we find that there is a lot of focus on funding things without as much thought into what are you funding and how are you doing it. When people have come to me to have conversations, I have said, look, we welcome all support, all technical assistance, but not just money. We're not a bank and we're not a market. So when you come, give us advice, bring ideas. Don't just bring cash and say, hey, what should we do? Here, we've got some money to fund it. That's good, but that's no longer enough because we want to work with you all. You're all experienced people. You've all been in the field. Many of you have been in public health in Nigeria while I was in school. So there's a lot that you know that I don't know, you know? So when you come and share your ideas, come and share your experience. It's not just about funding. It's not just about resources. The funding will take, we appreciate it, but we're not in the business of wasting money anymore. I think that is very important there. Human resources for health. We have a lot of issues around our human resources, as you know. I think just a couple of days ago, the president signed the bill on retaining or addressing the migration of healthcare workers in Nigeria. But, you know, we're focusing on everything from the production, but also the capacity building, making sure they have enough, they're well distributed, but also they have the right skills to provide services in the front line in an integrated way. And we can get into some more detail in the panel if necessary. But there are some low-hanging fruit when you talk about the migration of health workers. There's a small exercise that I like to do. Maybe I should do it here, actually. If you pardon me, I will get back to my presentation. But if you're a doctor in the room, can you raise up your hand for a second? Raise it well, please. If you're a nurse, join them. No, raise your hands, please. It's some exercise. Please stand up. Please stand up. If you're a doctor in the room. Okay, so we've got maybe 10, maybe 12, right? Okay. If you have seen a patient, actually treated a patient in the last year, raise up one hand. If you are treating patients, sit down. If you are treating patients, sit. If you are not, the rest of you stand to the end of the presentation. Therein is your health worker migration. Therein is your health worker migration. You know, the first step when you want to japa is you get a job at an NGO. Who doesn't know that? And there's nothing wrong with that. People should make their lives better. Please sit, friends. I'm guilty of the same thing. So, but it's to make a point. One of the things that I've started to do that I'm pushing very aggressively, and the minister is also very excited about this, is that all of you should go back to, you can keep your jobs, but can you work with your organizations, dedicate, even if it's one day a month, and go to the PHC near you. There is a lot of capacity, a lot of skills that you have. Brush it up. What you can brush up and learn in a day. The Jews who are busting in the seams and killing themselves, they couldn't learn it in 2 years. But also, all of it is not just clinical. Even just your administrative decision-making, prioritization, management acumen that you have learned. All of these facilities will benefit from it. So one of the things that I've done in my agencies, I've asked all of the clinicians there to go and dust up their license. And I've asked the registrar of the MDCN, you know, to give me a list. I will pay for it. You understand what I'm saying? And then let them find a PHC near them and go there and see patients. And I encourage you to do the same, you know. Technical support and capacity building, I spoke a little bit about that. Coordination and partnership, I kind of inferred that a little bit around the fact that trying to optimize resources, but also just measurement of what we're doing. Next slide, please. I mean, what did we meet? I don't think, if anybody knows all the problems in primary healthcare, you guys can tell me. So I'm not going to spend a lot of time on that. But the real issue that I would like to highlight is that yes, there's not enough of this. Yes, government is not doing enough of this. Yes, but you all too are not doing enough. With you all meaning the civil society, meaning the public health community, meaning the donors, meaning the implementers, in that what we have, we're not working together, or we were not working together to deploy them in a way that maximizes the outcome. If you don't have enough, at least the least you can do is make the best of what you have, right? And then figure out what the gap is. So we're trying to really address some of those gaps. Go ahead, next slide. I think everybody here should be well familiar with the blueprint that the coordinating minister articulated for the health sector when he came in. There are 4 pillars to that. One of them is really around strong institutions and accountability for the health sector. The other is around service delivery, which sits not solely on the primary healthcare system, but largely on the primary healthcare system, given the outcomes that the president has handed out to us to achieve through the Health Sector Renewal Investment Initiative. And there's also pillars around the value chain, which is really the business of health. How do you make sure that we guarantee our supply chains, but also how do you make sure that health stops being a liability sector to the economy? Because it shouldn't be in many environments, in many settings. If you think about manufacturing, if you think about even service delivery, health is a driver of GDP in many instances. If you all have a sense how much of our own money in Nigeria goes into building other economies on account of healthcare, is trying to take another look at how we capture some of that to start to build our own economy. And then, of course, there's the health security agenda that is being led by the National Primary Healthcare Development Agency, but certainly supported by the primary healthcare system. Again, whether you are FMOH, NCDC, UHC, NPHCDA, whoever you are, ultimately your interface with the Nigerian, with the community, ends at the primary health center. So we will talk a little bit about that. Next slide, please. When we looked at this at NPHCDA, we distilled this into our own strategy, really saying, what does this mean? If we are going to support the government to achieve this agenda, ambitious agenda that it has set up, what are we going to do? There's a whole suite of things around really positioning the NPHCDA itself to be able to provide good quality stewardship to the system, working with 36 states and the FCT to build out and deliver high quality primary healthcare system is complicated enough. Now we've got 774 LGAs, and we'll speak a little bit about that we need to do. So you need to have an organization that knows what it's doing, that has the capabilities to do it. So there are a number of initiative, strategic priorities that is helping us to do that. I think from a service delivery perspective, again, the primary health center is where the rubber meets the road. And there's no denying the fact that we sit around and talk a lot about how the PHC system isn't working, but where is the progress? What are we doing to make them better? So we have deliberately said, look, what we want to do, put a number to it, is that we've got lots of PHCs, 8,000 plus that are getting basic healthcare provision fund now. Can you at least make them work? Stop just pumping down money through, buildings that don't provide any quality services, but also increase that number, but increase it intelligently. So there is a politics of dividing things equally per ward, but we know that the wards are not the same in terms of population, in terms of disease burden, in terms of opportunity and deprivation. The wards are not the same, and I will speak a little bit more. So we will meet the political 1 per ward target, but beyond that, we want to be more intelligent. It's a difficult argument politically to make, but I think we're saying it's enough trying to solve a public health problem with a political solution. Sometimes that just doesn't jive. So somebody has to really, hold the bull by the horn. Is that how they say it? And try to do things a little differently. So as we're expanding, we're going to be trying to address inequalities in access, because what we found, and I will show you later on, is that we basically I just asked for a simple analysis. I said, okay, what should we focus on? What should we solve? And the way to solve that is take all of the attributes that you know at the, we should get to state level. The states that we had more data at the LG level was exactly the same. Take all of the outcomes that we outcome and take maternal mortality, for example. Just what are the factors that correlate with it? And I thought it would be actually the population. So if you have too few for the population, but I was wrong. Actually, when you did the analysis, it had very little to do with the population. It had more to do with the distance size of the LGA. And once reflected, I'm an epidemiologist, so I do know how to run regressions. So that involved a lot of adjustment. Wondering, it was a properly done analysis, just to be clear. And it was because, if you think about it, the ability of a pregnant woman who is in labor to get skilled birth attendance is a lot more related to her ability to the health facility. Even if there's a crowd, they will prioritize you if you are in labor. True or false? True or false? Okay. Tell me if I'm wrong, if you're on the ground. If that's a wrong assumption, tell me. But that then made sense. That was the explanation that somebody gave me, that actually it's about your ability to get to the facility where the service is available. If you get there, you will, somebody will attend to you if you are in labor. So it's not so much about the crowd. It's not so much about the volume of people. It's more about your ability to get to it. So one of the things that we're doing is really solving for distance, high quality facilities over certain specified distances. Thank you. Related to that is the Basic Healthcare Provision Funds, which is the core of the domestic financing for primary healthcare services. I think fortunately for us, we met on ground thanks to the work that people like Dr. Lecky and some other participants in her fund done, all of the advocacy and work that we did earlier on. We have the Basic Healthcare Provision Fund. We have the National Health Act. Substantial amount of money going every quarter through the NPHCDA, through the 4 gateways, actually. NPHCDA is one of the larger ones, to the states, to the health facilities, to finance service delivery. What we found was, again, a lot of waste. A lot of facilities that don't even exist, no correlation, no accountability. We've stopped all of that. So I can tell you that as of today, there's no facility that is getting money from Basic Healthcare Provision funds that is not providing services. Are they all providing services to the level that you want? No, but at least part of your responsibility go in the community. If you find one that doesn't exist that is collecting money, let me know. I want to know so that we will address it. But we'll talk a little bit more about how you can support us later on. Related to that is the quality of care, whether you're talking about routine immunization, you're talking about nutrition, you're talking about MNCH. There's certain interventions that we're putting in place to address many of that. I think that's my cue that I'm talking too much. So the slide has moved on its own. So the PHCs, we defined what is a minimum quality that we want in a primary health center. And I want everybody to pay attention to this, because this is what we want you to work with us to help us achieve. We looked at the 8,400 today that meets the bar that we're giving money to. Just about 20% of them, 1 in 5, actually have and the definition is this: if you're going to save the life of a mother, I think it was Sydney that said it earlier, We want to make sure that a woman can safely walk into a facility and get delivered safely. That has in it many things. You have health workers that can deliver you. They are there around the clock because labor does not happen in the morning or afternoon. It happens at any time and stretches over. That means if you're going to be able to work at night, that means you have power. If you're going to be able to take delivery, you have water that is running. You have wash facilities, you have toilets, right? But also the building itself is dignified enough. There are windows and doors. No women aren't going to come and expose themselves to be birthed where there is no window or a door or under a tree. You see what I'm saying? So just in that simple definition, it tells you what you really need to do. And if you can do that, you can administer vaccines, you can administer treatment, you can do diagnostics, you can do many other things. So that's the bar. And we said, look, we looked at the data again and said the facilities that are doing that, what are they actually using at a minimum? And it is one, you have 6 or more skilled birth attendants. And we say that very carefully, whether you're a doctor, you're a midwife, you're a Jew, but you're trained to be able to take deliveries safely. That's a skilled birth attendant. You have at least 2 at any point in time. So if you're running 3 shifts, that's 6 or more. In many places, they don't have up to 6. They have 4, but they have accommodation. So they're there. So, and many of you who have done rural medicine or rural practice know that in many of these places, you are in your quarters. When somebody comes, hey, doctor, nurse, we're in labor. You come out and you attend to them. We find that that's, so if you have accommodation, you can deal with a little bit fewer. But ideally, you want to have 6 or more. We have all of the issues of our health worker shortages that makes that difficult. I talked about power. I talked about accommodation and security, fencing, things like that. And of course, wash services included into that. Next page. So we did an assessment. I talked about this, I believe. So if you look at what they call level 2 here, it's just about 20%, 21%. Today, well, not today, actually, it's a little bit more than this. But when we came on board and did an assessment, that's the proportion that meet that basic criterion, right? So our goal is to increase that number. So all of those ones that are in level 1, we want to move them to level 2, and we need your help doing that. You know, you can be one of those skilled birth attendants. I'm just kidding. Don't quit your jobs, but you can hire and support some, work with your states, the advocacy that you're doing. We'll talk a little bit more about that. Let's go. Next slide. There are many different types of gaps. Some facilities don't have workers, some don't have power, some don't have. There are many reasons why they don't meet the bar of what we are asking for, but this is some of the breakdown of the data. Please, next slide. The gaps are not equal across the zones. Even within zones, there's a substantial amount of variability between states. So we're trying to be intelligent with the way we work on these things. And we already have 500 of these PHCs that are already earmarked. We're doing, what do we call them? BOQ. What is BOQ? Bill of quantities. Right now, you get what the consultants are out there to upgrade them, and we will communicate. One of the things that we're doing is we have a draft dashboard now that will be live, that you can go and see the state of the facilities, so that as they are increasing, all of you can see it. And we have many other mechanisms that we have put in place to track that investments that we're making, and we're working with the states through World Bank and other sources, BHCPF sources. Literally, there's going to be another 3,000 to 4,000 facilities that will be revitalized over the next 1 year. By the grace of God, that's our target alone over the next 1 year. That process has started. They're already doing their BOQs. The money is already on ground. They are with the states. We are going to provide oversight. We have signed an MOU with ICPC. When I issue a contract, or when you tell me as a state that this is your list, I'm going to give it to ICPC. Go and look for us. If somebody says they are doing this, they're not doing it, come and let us know. We want you also to go and look. So we want you to be involved. Come to the table, have the information, and tell us. Not to embarrass us or throw under the bus, but I cannot be everywhere. So if you come and tell us that, look, this person didn't really build the PHCO, they are just lying, that's useful information for our own decision making. Let's go on. Next slide. I talked about this already. Some of the factors that affect maternal outcomes, for example, the two biggest ones are presence, access to skilled birth attendants, and literally distance from a facility that you can receive the services. There are a number of other things that you already know. Let's go. We're doing some things really then looking at, we want to work with the states to increase the density of skilled birth attendants. We have done some archetyping to say there's some where they have poor outcomes and no facilities, some have poor outcomes and some facilities. The way we're supporting them is a little different. That's what this really says. Let's go. Let's go. You need skilled birth attendants. That's what we're saying. We hope to serve some 6 million women, over the next 3 years, in addition to what we're already serving now. By the way, we just submitted the Q2, or we're actually in the process of submitting. We have not submitted the Q2 reports to the president's office on the compact. And I'm happy to tell you that we're already starting to see the results of some of this. If you look at just the number of people that are receiving services, of course, it's difficult to measure outcomes at this point yet, but when you look at the number of people, whether you look at immunization, Penta 3, whether you look at antenatal care, the fourth attendance, whether you look at deliveries, whether you look at actually all of them are trending up slowly. 10% increase per quarter, 12% increase, 7% increase, but they're not stagnant and they're not going down. So I think that's a good start. We hope to see an acceleration as we expand the number of retail outlets. There's one outcome that went up, and there's a good explanation for that, and that is the number of recorded deaths in the facility. And you expect that because we just weren't reporting it before at all. So one of the things that we're doing is trying to be a bit more honest. Can we improve? We have some intervention called CEM, who is in the acronyms always. Yes, MPDSR, that's what it's called. I really don't know what it stands for, but what it means is that we're trying to make sure the facilities actually record vital events, that are happening in all of them, and we're really pushing that. So the reporting rates are going up, and that's being led by our CHS department. So for me, that's a positive outcome. The fact that that number is going up, what we're trying to figure out is what level of up is enough that you want to start to see it trend down, because you can't keep going up forever in the number of deaths that you are recording in your facility. So we're trying to find an intelligent way to determine that. Next slide, please. The community health worker program, we have also done a revamp. We've redesigned a whole new program. All of you are familiar with different, if you're UNICEF, you know about the VCMs. If you are around the NPHCDA, you know about the CHIPS program. All of them are well-intended attempts to bridge the gaps in the primary healthcare system. Even when we have 17,000 facilities, it's still not going to be close enough to every Nigerian. So you still need a last mile effort to be able to take some basic services, even where it is basic health promotion, to some Nigerians who just don't have the wherewithal to go to these facilities. So we have put some thought into what should that really look like and how can that work. And we're really engaging with the states, and we have some very exciting prospects. Just to talk to a lot of governors. We're talking just 2 days ago, one of the governors was in my office, where we really just got into the details of this in particular. And go ahead, next slide. And the idea is to have this frontline workforce go back to the basics, part of our going to how PhD should be done. When we were growing up, you had community health workers in the community. And basically what they did was you will assign everybody, every household, to the responsibility of a community health worker who knows you, who knows your needs, who knows if you have 250 households or you have 1,000 people in the community that are your responsibility, even there in the community, you will know who is pregnant. It's quite unlikely. Level of training, there's a range of services that they are going to be able to provide. We are mobilizing partner resources to incentivize the states to hire them. By the way, in the context of the LGA autonomy, one of the things that we're really working on very aggressively is to preserve the sanctity of primary healthcare under one roof, which is, really using this opportunity, see it as an opportunity to step up the collaboration between the federal, the state, and the local government authorities to do what the National Health Act has already prescribed, which is that there is a fund, for PHC services that is co-financed at the 3 levels at prescribed levels, and everybody is excited about that. So we're really working with the Attorney General's office to look at all of the laws that are guiding, because what happened is that we had the National Health Policy, we had PHC under one roof in 2011, we had the National Health Act in 2014, we've had all kinds of states, NPHCDA laws, we have the NPHCDA law that predated all of this. There's not a lot of sync in all of this. So we're now in the process of working to try to sync all of the laws to really coalesce around our National Health Act so that we really start to implement a national health system to make sure that we continue with things don't fall through the cracks and don't go back to the days of complete fragmentation. Next slide, please. Okay. Yeah, this I kind of already spoke to. Next slide. Yes, so how can you support us? I will speak to a couple of things, but I really look forward to a few more ideas as we have a conversation later on. I think the first thing, I've heard the word accountability bandied around or said quite a bit today, but I want to agree with, I think it was Ayo Sinlu who said it's not always about money. Money is important. So if somebody is chopping PHC money somewhere, please tell us, let us know. We want to know, okay? So that we do something about that. But also, it's feedback. If we say, when we launch this, our PHC functionality dashboard, if we say this PHC has 6 skilled birth attendants, when you go there, do they actually have 6? Or has somebody japat and they did not replace or they did not tell us? Do you get what I'm saying? Let us know so that we can take action on it. If we say that they have functional power, solar backup for 24 hours today, or do they not? If they say you can find reproductive health services, you can find delivery services, and you go there and they say we don't have the commodities or equipment to deliver this service, we would like to know so that we will address it. I think that's one major thing. I spoke a little bit about service delivery. CSOs and women groups and NGOs have forever and everywhere been a critical part of service delivery. It's not sustainable for it all to be government. Government isn't that good at regulating and providing services at the same time. But for now, government has to provide a lot of it. But I think you have a shared burden and responsibility. You all have nice and juicy careers off of the fact that the health sector sucks. So you have a responsibility. Does that mean I really need to go? No matter what you do, you all have a responsibility to help us. You should ask us to do more, but you need to also do more, to help Nigerians. You are part of us. In fact, I used to joke with Auntie Muji that the UHC forum should really be advocacy and communication department of NPHCDA, So, because I think it's the same thing that they're doing that you really should be doing. Yes, and I think the third thing is really around to help us tell our stories. Part of the feedback that we get a lot, and we hear it, is that we don't talk enough, we don't engage enough, we don't communicate enough what we are doing. But the truth of the matter is, to the extent that you are not getting enough real help doing the work, if you are going to be able to move at the dizzying speed that Dr. Lecky spoke about, you have to prioritize, do I get the work done or do I go around talking about the work? That's just the truth of the balance that you have to make sometimes. So at least you all can come around, see what we're doing and help us tell our stories. Thank you.
Well, thank you very much, sir. Well, thank you. We just received the presentation of the Executive Director, CEO of the NPHCDA, Nigeria, Dr. Mui Aino. You presented him with an agenda for this forum, and then he has presented you with his own agenda. He will try to do more, but he needs you also to do more. And if he does more and we do more, then the objectives of this platform are very safe. We're almost home, safe and dry. Thank you very much, sir. We still keep very optimistic. There was a buzz around town when you showed up at NPHCDA because we knew what you could do with that assignment. We are conversant with the knowledge base, the expertise, but perhaps above all of that, the passion. If you have known him for the years that I have known him, you would know what I'm talking about when I talk about his passion for anything that is set in his hands. And I'm sure that's sufficient to quickly just press forward now and invite Lucia Laboso, the the project director for E4A, Mamaye. She's my friend from Kenya, and today she'll be speaking about accountability. Thank you, Lucia. Please welcome.
Thank you very much. Thank you very much. I will not introduce myself. I think we have already mentioned who I am. Allow me to stand on already established protocol. It's a privilege to be here to share about our experiences as options on the accountability work, and especially the lessons that are drawn from the state-led accountability mechanisms. So as we wait for the technology, as it's called, it's really great to be here. I'm from Kenya, and as somebody mentioned, there are certain colleagues that are in the crowd from Kenya, and I'll be talking about the reason why. Our continent is very much, we have a lot of similarities. Each country is unique indeed, but we also know that there are lots of similarities, and the more we learn from each other, the better. So let me embark on the presentation. And the theme is really raising the accountability bar for PHC delivery and drawing from the lessons of the state-led accountability mechanisms, which I'll refer going forward as slums. I think most of us know what slums are. In other countries, if you mention slums, they'll think the settlement areas. But in Nigeria, I think our brains, especially in the NGO sector, we go right into the state-led accountability mechanisms. And that's the overview of my presentation. I will not read word for word in the interest of time. I know we are racing against time. So next slide. At Options, we do quite a number of things. And in our advocacy and accountability work, we strengthen the organizational and technical capacities of the slums to synthesize and use data to improve health outcomes. And we do this through amplifying the voices of the communities, equipping them with the tools and the strategies to harness the power of data that can drive change through decision-making, and then building trust across diverse stakeholders, and also supporting inclusive and participatory health systems. We can always talk about let's engage communities, but we really need to start and improve on walking the talk, ensuring that communities indeed are at the center. Next slide, please. So this is our global impact. This goes beyond Nigeria. We have strengthened the technical capacity of over 39 accountability mechanisms and coalitions in 19 countries. We have also strengthened and supported 300 civil society organizations to advocate and hold governments accountable on their commitments. And the $152 million is really the additional resources that have gone into health as a result of our advocacy and accountability efforts. Next slide. So zooming in to Nigeria, the country where we are in, the giant of Africa, as it's called, that is where our footprints as Options has been over the years through and across a number of programs. And these are like 18 states where we've had projects over the years, over 22 years of experience in this country. So we are young adults as far as Nigeria is concerned. And you can see the programs that we run, and I am going to talk more about the Evidence for Action program, which I lead. Next. So even as we move to the Evidence for Action program, through all our programs, just to give an example, in Jigawa State, through the advocacy and involvement with the slums, we had, for the first time, the creation of a family planning budget line and an initial allocation of 10 million in 2020, which was increased twofold in 2021 to 20 million. And in 2022, it went to 30 million. So you can see that step by step through accountability at local level, involving local stakeholders and a diversity of voices, there is progress that is made, because we know that family planning in itself saves lives. Maternal deaths can be decreased using access to family planning. Evidence for Action, or E4A Mama Ye program, has been running for 12 years now, over 12 years, having been funded initially by the now FCDO, then DFID. And then after 5 years, the Gates Foundation got on board, and we've had several iterations. And this is the accountability model that we have been utilizing. And we can see that at the core really is data. I think our name as Evidence for Action really tells us where the DNA lies. Evidence, evidence, evidence. Because with data and with information, we are able to really do what is needed and what is realistic as far as the local needs are concerned. We also have gender intentionality. We have mainstream gender in the way that we work, not just at technical, but also ensuring as we do the root cause analysis of maternal deaths, we look at the gender dynamics and power dynamics within communities, within families that continue to drive preventable maternal deaths? And also at the decision-making level, how are we considering the gender norms, including even within the slums itself, the leadership? What voice are the women having, the men? How are they involved? How are communities getting? So to give an example, we did have, in some slums where majority of the leadership would be men. And the question would be, where are the women in this slum? And they'd say, okay, they are not educated enough to lead. And the question that we would always ask is, why are the women maybe less confident or don't have the education? And can they participate even in their local languages? There is the linguistic alienation of women, saying you must always write a report in a certain template, you must speak in English in order to be heard. So further and further, we are talking about involving those that are, with the lived experiences, and ensuring that they can participate where they are and in the way that they can do it. Whether it's language, they should speak in the language that they are comfortable in. And we have the tools also. You'll see that we have, we've mentioned about scorecards. Scorecards are also part of our modus operandi. And while looking at the blueprint, the PHC or the NPHCDA blueprint, the question in our minds was, can we also have a scorecard? I think the ED mentioned about the functionality dashboard. How are we measuring ourselves? How are we tracking our progress? How are we looking at what we have committed, where we are at, and how we can even make more progress on it? Let's go to the next slide. So definitely take my word for it, but more importantly, I want us to hear from the horse's mouth by giving an example of what the state-led accountability mechanism in Lagos did and what results they have achieved as using the strategies and the tools that I've just mentioned. I hope we can play at least 4 minutes of this in the interest of time.
Last time. Lafiya ina wannan abokin Badu yana gida baka je wajen abokinka ba ne sunansa ne
Sorry, I'm not sure that is the audio in the video. I don't know what's going on.
Ahmed, can you mute yourself, please?
So as that is sorted out, really what will stand out in that video, if we are able to play it, is the need for political will and local ownership, having a listening government. The beauty of the slums, really, and this is very unique to Nigeria, is that civil society, private sector, the media, and the government are part and parcel of the accountability mechanisms. So when the data is being generated, when the data is being analyzed, there is nobody pointing fingers and saying, you failed on this, or this data is inaccurate, because you're all in the same place. There is mutual accountability. There is work that is done together, and also generating advocacy briefs, memos, and the scorecards, and taking action on it. There's also involvement of a diversity of actors, again, as I've mentioned. So that all those voices come together and analyze the data and also identify the asks, because the decision makers could be at very different levels. So when we have the right asks that are driven by evidence, then we can have the right decisions that are made for the benefit of the community. So I think we can play the video afterwards if it works, just so that we are moving forward. I think we should already be hearing some audio, so I'm taking it that technology has decided to fail me this time. So we can go to the next slide. Thank you for, we can play it maybe during break and people can follow. Sorry about that. Let's go to the next slide, kindly. Yeah. So these are some of the key results and mentioning actually what would come out of the video about the zero stockouts, following consistent and persistent advocacy, and also the accountability work that was done by the slum. There was life-saving commodities that are fully stocked in 2016. I mean, from 2016, there was a stock out of 65%, and it went down to 0 in 2020, which the decision makers attributed specifically to the actions of the slums. And we also have examples from Bauchi, Kaduna, Yobe, and Niger. I will not read through all, but in Kaduna, and the ED mentioned about the community MPDSR. We have MPDSR scorecards that the slums utilize, but we also have community MPDSR in which we piloted in Soba community, social autopsy, which integrated for every mother that dies or a child that dies, there is social autopsy to look at why did this mother die? What could have been done? Yeah, so that no other mother dies as a result of the same cause. And what we've seen there is really life-changing, because the men and the women are speaking together. And for example, one of the output is the transport union committing to take mothers to for skilled birth delivery or to the PHCs when they need to deliver. So for free, that is, because transport was considered to be one of the barriers. Let's move on. So we're looking at, that is what we have been doing. Now, looking into the future, because there's, I see I have 5 minutes. I think that is more than enough, actually. Thank you. So we are looking into the future. We've talked a lot about community involvement. We've talked about accountability. We've talked about ensuring that we are walking the talk. I was looking at the maternal deaths, you know, when this was put up about quite a number of countries in Africa, the MMR in Africa. And it reminded me of the just ended Olympics. Everybody was clamoring for gold. As a Kenyan, you know, we tried to get as much gold as possible in athletics, although obviously there's a lot of competition. Now, when we looked at the chart, I don't think anyone wants a prize or a gold medal for having the highest number of maternal deaths. So it's really time for us to look at where have we gone wrong and what do we do for the future. They say that if you want different results, you cannot continue to do the same things. You cannot speak to ourselves all the time. We are speaking in an echo chamber over the years, while we keep talking about we need to involve communities, we need to involve communities. The time for action is now. And the old adage that says, if you want to walk fast, or if you want to go fast, you walk alone. And if you want to go far, you walk together. So if you want to go quickly, you can go alone, but if you want to go very far, you walk together. And this is what we are talking about with the Mama Ye Africa Collective. I'm sure during the introductions, everybody was wondering, who are these people? It's the new kid on the block. And the reason why we have the Mama Ye Africa Collective is grassroots advocates have been speaking with each other together and seeing over the years that we talk about it's 6 years to the SDGs, the end of the SDGs in 2030. And yet we are off the track. We say we are off the rails, but what are we doing about it? We cannot continue to do the same things. The commitments that are being made, the strategies that are being made to meet these the sustainable goals need to have the voice and the involvement of local actors. And as the curtain falls on the Evidence for Action Mama Ye program, we have the Mama Ye Africa Collective, which really is a pertinent partner, a worthy partner that is a movement of grassroots advocates across different countries. And we welcome you to support them, to reach out to them, to work with them. And we believe that they can amplify the voices, not just at local level, but also at national, regional, and at global level. And we hope that we can get back on track in reducing maternal deaths in Africa and in Nigeria. Thank you very much.